is Ramón Llull. I'm a plastic surgeon and an immunologist at Wake Forest Institute of Regenerative Medicine and the Department of Plastic Surgery at Wake Forest in Winston-Salem, North Carolina. Ever since my 20s, started an immunology research that migrated into adipose tissue, into fat. The reason being is that adipose tissue contains a significant amount of cells easy to harvest, and that provided plenty of material for posterior research. The way that we can make good use of this fat, this adipose tissue, is to process it, is to harvest it and then process it into smaller fragments in such a way that it can be implanted back into different sites. With that in mind, this product, these tissues processed that way, then can be used for both reconstructive and aesthetic surgery. In some occasions, we need a filler action. In some other occasions, we need a repair, a healing action. The best or the most popular way is by harvesting it via a liposuction. A very common procedure is renders a small amount of tissues, or should say a small size of fragments. These fragments are too big for them to be implanted in areas just like in the face, where the skin is very thin and therefore it would be bumpy. That's why fragmenting the adipose tissue became clinically useful, because we would have, rather than big blocks of fat, we would have much smaller fragmented blocks of fat that would be able to pave or to be implanted in the thin skin areas of our anatomy. The way that patients respond to the offer, I'm going to use fat from other parts of your body to place them into your face or your breast, then they are taken by surprise, but also they are happy to hear that. It seems to be that is a win-win situation by which they get rid of some fat storage that is not necessarily wanted, and then placed to a better use somewhere else in their bodies. There are two components of the benefits of adipose tissue transfer. One is a filler effect. The fat graft is able to fill up a defect and therefore restore the shape or the contour of a given area of our body. This takes a short time and is preceded by a time in which the area is far more swollen than it should be. So then the edema, the inflammation after the implantation subsides and goes away, then you can see readily the effects of that filling action. There is another more subtle effect, but it appears more and more powerful, which is the regenerative aspect. It is the effect of looking at a tissue, seeing that it has been aged, is wrinkled, deflated, lax, sagging, and then all of a sudden, by implanting these small little fragments of adipose tissue, then we obtain a more terse, a more supple, nice, empty, shiny tissue. And that is particularly evident in the face. One of the aspects that was surprising on the patients was that the effect is delayed, but then it's very apparent and long-standing. We share a hypothesis, a thought, by which we believe that if we were able to deliver right at the injury site, at the site of treatment, a number of cells, then these cells would be able to exert a therapeutic benefit on that site. This hypothesis seems to be holding up over the past decade or so, when we initiated this long walk of trying to understand how we can change the way we heal by using our own cells. So with that in mind, delivering a number of cells to the injury site so we can just repair that site better, we thought that the more the cells, the better. Of course, we could not go everywhere in our body because everybody is jealous of, let's say, their own bone marrow cells, not to mention the brain cells, you know, and these are difficult to, or sometimes impossible to harvest. However, adipose tissue, fat, it is an accessory tissue, accessible because it is immediately below our skin, and expendable. So we could just make good use of that otherwise discardable tissue and obtain a number of cells that could have this effect. What it was tremendously interesting is that we could just get not more cells, but far more cells than that by mechanically stripping the adipocytes, the cells containing the liquid fat, away. And then the product of that would be a highly concentrated strings of full of regenerative cells. So by removing all these big balls that are full of fat, liquid fat, and then concentrating all these strings into a smaller volume, we would have a high density of cells implant for us to work with. This was a disruptive finding. It was an interesting finding. Tissue engineering, all tissue engineering is based on a very simple concept. I put cells, I put matrix, I put vessels, and voila, here's a new tissue. Well, this has been tried for a couple decades already, and we have to say with little or no success. And the reason is that nature does not work like that. We are not built like that. Tissues are not built like that. We don't add these components, even though they are components of the tissue, adding them will not result into a functional tissue. Now, what we have to do is use these little clusters of highly dense populated with cells. So then we can just do a quantum leap in the development of new tissues, in the development of new regenerative therapy that encompass the delivery of this great amount of tissues into our great amount of cells into our tissues. The results on the laboratory bench are extremely encouraging. Contrary to the expected, this mechanical aggression, this mechanical stripping and mincing and destroying of adipose tissue does not end up with dead cells. The cells that are left are quite alive, and now we know functional. They do what they're meant to do, even though they have been fragmented, minced, sheared, and mishandled all with different processes that we expose them to. In this context, I feel that is far beyond using it for reconstructive or aesthetic surgery. I think it is revolutionary in the way that the units, the blocks, the building blocks of tissue engineering are not these former units, but are rather more complex units, far richer and far more adept to make their job at reconstructing a given tissue, at rebuilding a given tissue. Breast reconstruction after cancer resection has taken a different route with the option of having the possibility to graft adipose tissue into these absent breasts. So now we use in a significant number of patients these fat grafting techniques, either by itself or with the use of nanofat or stromovascular fraction cells, which are these regenerative cells that we use to enhance the take of these grafts and then, reconstruct what cancer has taken away. Among the different applications of this technology, I include my two different clinical activities